And I wanted to get your attention to let you know that there are people still trying to find parking spaces outside. You can kind of see how busy it is. So if you indulge us all, just keep it to a slow roar for a couple more minutes to make sure everyone who wants to come can be in the room and not disturb our presenters. I'll take just a couple of minutes. My name is Jack Ekman. I co-chair the Healthcare Directions Committee here in Big Sky and in West Yellowstone. And we really thank so much our guests, our neighbors from West Yellowstone for being here this evening. There's quite a representation present. Billings Clinic and Bozeman Deaconess Hospital have both made proposals to the community of Big Sky and West Yellowstone. We are absolutely so fortunate to have that in our communities. And tonight, I very much want a respectful audience to our guests from Bozeman and our guests from Billings. We had a coin flip on Monday morning to see who would go first this evening. And however you look at it, Billings Clinic will go first. We're not sure if they won the coin flip or if they lost the coin flip, but they are going to go first. Here's our agenda for the evening. Billings Clinic will present a 40-minute presentation, followed by a 20-minute question and answer period. So hold your questions through the presentations for the 20 minutes, and we hope all your questions get answered by their representatives at that time. We'll take a 10-minute break after the question and answer period for Billings Clinic, so that Bozeman Deaconess Hospital can set up their presentation, and we'd like everybody back within that 10-minute time period. After the presentation and the question and answer period from Bozeman Deaconess Hospital, Mike Scholes, co-chair, will be up here and he'll discuss next steps in the process. It is my pleasure at this time to introduce the Chief Executive Officer of Billings Clinic, Nicholas Walter, MD. Dr. Walter is CEO of a fully integrated health system in South Central Montana. Billings Clinic includes a 240-physician multi-specialty group practice, a 285-bed acute care hospital, multiple regional clinics, and a long-term care facility. Billings Clinic also manages 10 critical access hospitals. Billings Clinic has focused its core strategy on improvements and outstanding performance in areas of patient safety, quality, service, and value to patients and their families. Dr. Walter is a former member of the Board of Directors of the American Hospital Association and the American Medical Group Association. He also served 2 terms as a commissioner on the Medicare Payment Advisory Commission, and he is a frequent speaker on healthcare delivery and payment reform. Dr. Walter was recognized by MGMA in 2004 as Physician Executive of the Year. He was named by Modern Healthcare as one of the 100 most influential people in healthcare in 2010 and 2011, and by Modern Physicians as one of the 50 most influential physicians in healthcare in 2011 and 2012. Dr. Walter received his BA in English at Carleton College, his MA in American Culture at the University of Michigan, and his MD at the University of Michigan Medical Center. He completed his internship and residency in internal medicine at Bassett Healthcare in Cooperstown, New York, and returned to the University of Michigan for a fellowship in pulmonary and critical care medicine. He joined Billings Clinic in 1982 to practice pulmonary and critical care medicine and was appointed Chief Executive Officer in 1997. If you haven't turned off your cell phones as yet, please turn off your cell phones, put them on vibrate, whatever it takes. It is my pleasure to introduce Dr. Nicholas Walter.
Is it working, Luke? Can we get rid of that box? Computer science was never in my skill set, but hopefully this will work. We do appreciate the opportunity to be here. Roughly a year or so ago, we did get asked by several community leaders here to come in and look at what we might consider proposing in terms of advancing some healthcare facility and operational capacity here in Big Sky, and it's really been enjoyable to learn much more about the area and to kind of look at how that might come together here. So we appreciate the opportunity. I wanted to start with just a few things about the Billings Clinic. Many of you may not know very much about us. And as I get into that, I thought I would start by introducing some of the members of my team that are here. And I'd like to start with one of our current board members, and if each of you would just stand up as I read your name. Penny Nance has been a foundation board member, now a board member on the clinic board, very active on our clinical quality committee. She's here with her husband, Bob Nance, who had been a board member, Bob, thank you very much, back when the clinic and Deaconess Medical Center merged. And we had a lot of fun in those years, Bob, but I think his founding presence on what it meant for a hospital and clinic to come together was very important. Also wanted to recognize Kyle G., who is our regional CFO. Kyle's been with us 16 years, 13 years in the region, and is about experienced with critical access hospital finance as you can get. Scott Duke, relatively new with us, he is our regional operations vice president. Connie Pruitt, thank you, Connie. Connie is our CFO. Connie spent a lot of time with physician practices earlier in her career, then was CFO in Montrose, Colorado, a smaller community, although certainly larger than what we're talking about here. Jim Duncan. Jim is our foundation president and has done a tremendous job working with our foundation, but also working with some of the foundations in the region. Mitch Goplin. Mitch is our Vice President of Facility Services. You'll hear a little bit more about some of the facility work that we've done. Chris Stevens. Chris is our CIO and has developed one of the most active regional information technology strategies and presence in this region. And then we're really pleased to have with us Linda Harris. Linda is a board member at Beartooth, Billings Clinic in Red Lodge, and Kelly Evans, the CEO at Beartooth Billings Clinic in Red Lodge. We've had a very long association with them, which we'll touch on just a bit later. So the clinic is a somewhat unique organization. At our core, we're a physician group. We're a large multi-specialty group practice. We look at pairing physicians with outstanding business people in terms of how we operate. We are not-for-profit and community-owned, and the Deaconess part of our merger continues to be a strong presence in the sense that we're not-for-profit, community-governed, and very committed to appropriate charity care and higher purpose goals. We are very driven by the missions that we have been created, which include the region, and we have placed quality and service as kind of the foremost thing that we really wish to excel at. Our vision really is to be a national leader in those areas of quality, patient safety, service, and we've recently added value. There is so much emphasis now on healthcare costs and how those are better managed that we've done a lot of work, which I won't cover tonight, in the Lean Six Sigma area in terms of how we manage cost. But quality, safety, and service really have been very important to us. Won't read all of these names. We have an incredibly strong board of directors strong business skills across a number of industries, and our board is very active, number of subcommittees, including a committee of the board which works on regional strategy and regional relationships. I'll get this right. Our foundation board is also a board with a lot of breadth and depth, both in terms of business experience, community involvement, and our foundation board also includes staff and physicians from our organization. And again, without reading all of these, I want to give you a little flavor for that. Our foundation has been pretty important to all the things that we have done in recent years. We would not have been able to do the various types of things we've done to deliver better care and higher quality care in a way that really serves our patients well had we not had a strong foundation presence. And I'm going to just ask Jim Duncan to make a couple comments related to our foundation work.
Thanks. It's great to be here tonight. And I wanted to just share that if you look at all the great healthcare organizations in the country, large and small, all of them achieve higher levels of greatness because of philanthropy. If you think about the Mayo Clinics and so forth. And at Billings Clinic, that's been a hallmark for us as well. We've raised about $100 million since our founding as a foundation in the 1980s. We've distributed about $65 million for different projects and technology and facilities. And we have about $40 million that we manage in assets right now, endowments and so forth. In this proposal that we're putting forward, we think philanthropy can and should play a key role. It builds a lot of community ownership and investment in the organization so that there is a pride of what's accomplished. The $5 million that you'll hear more about that we're recommending for a capital campaign will certainly be vetted as we work with the community and have professional assistance along the way. In Sun Valley, Idaho, they built a new hospital. They had a $12 million capital campaign goal. They raised $20 million. In Whitefish, they built a new hospital. They raised $6.3 million for their new hospital. As you saw, Livingston Healthcare is underway with the new hospital capital campaign plan, and we're hoping that they will exceed their goal. Beartooth Billings Clinic just recently completed a campaign, about $4 million raised. Our foundation will stand ready to serve, help, assist, and guide, and add to this community because this is all part of what will make our healthcare community stronger. So, thank you.
Thanks, Jim. And I did want him to touch on those things. As many of you know, the committee certainly knows, part of our proposal has included the thought that we would raise $5 million in philanthropy to help us get this project off the ground. We have considerable confidence that that's very doable based on our own experience and experience in other similar communities. Of course, it will take some big sky leadership involvement, but I think we have really quite high confidence in that part of our proposal. I wanted also just to say we have a lot of breadth and depth on the leadership team. You've met quite a few of them already tonight. There are several that could not be here, but we really can support the various communities that we work with, not only with the leadership team support, but at the director and manager level. We have a tremendous amount of support available to the CEOs who work for us out in the region and support those community boards, and that makes a huge difference in terms of the resources required to operate a smaller hospital and clinic at a very, very high level. And then I wanted to mention our Leadership Council at the Billings Clinic. And the Leadership Council meets twice a month. It consists of some senior executives and then about 7 physicians who are elected by their 240 peers. And this is really an internal board. There are almost no decisions going through the Billings Clinic and up into our community board that are not first vetted and considered by this group. These physicians take their responsibility very, very seriously, and their colleagues hold their feet to the ground in terms of if this organization, the Billings Clinic, is going to be making complex decisions, we want to be sure you're in the mix and that you are presenting the physician's point of view, but also representing what's best for the organization, all of our staff, and all of our patients. This is somewhat modeled after what some of the other larger integrated systems do, such as Geisinger or Virginia Mason or Mayo, and we do have a very strong philosophy around the importance of physician leadership, along with the importance of a strong community board. We have about 3,600 employees. We mentioned our physician numbers and mid-levels. We are a Magnet designated institution, which is about 350 hospitals in the country receive that nursing designation. It's very hard to attain, and we have now achieved that designation twice. We have about 900,000 patient encounters. We have 10 clinic locations, including some that are quite rural. We're licensed for 285 beds, over 14,000 admissions a year, and about 40,000 emergency room visits a year. We probably have the largest psychiatric set of services in the state, which we have stuck with through thick and thin, even with all the various reimbursement issues related to mental health. We're very active in research. I won't spend a lot of time on that tonight, and we've covered our foundation activity. And then just to give you a sense, Montana is a very interesting state in that there are, I think it's 10 or 11 what's called PPS hospitals. PPS stands for Prospective Payment System, and that's different than Critical Access Hospital. And Critical Access Hospital is a phrase that really stands for how payment comes from Medicare. And that's different than how it comes in the PPS system. But by a considerable margin, we are currently the largest healthcare facility in the state of Montana in terms of both the hospital and clinic operation. And part of that is the regional footprint and the regional partnerships that we have now in Montana and northern Wyoming, and one at least in western North Dakota. We are pretty broad and deep in terms of the number of specialties that we now have at the clinic. I'm not going to read the list, but we brought the first cardiology and invasive cardiology into the state, the first cardiac surgery, the first nephrology and dialysis, the first oncologist, and we tend to be an early adopter in terms of the services that we bring into the organization. The most recent example of that would be GYN oncology. We're very committed to community benefit, deliver the largest amount of charity care in the state, and actually we're one of the early adopters through an organization we once belonged to called VHA in how standards for community benefit and charity care should be reported. In fact, I had the pleasure of testifying and meeting with the IRS on those standards when they were developing some of them in terms of what really made the most sense to focus on. Some of you may have seen an announcement we made in January that we have become part of the Mayo Clinic Care Network. The Mayo Clinic has 3 main campuses, Jacksonville, Scottsdale, Rochester. They have another group of organizations in their 120-mile radius called Mayo Health System, and their care network is their newest approach to how they partner and can bring resources to organizations in a broader geographical array. I think they're up now to 19 or 20 organizations in their care network. It's a fairly strict amount of due diligence one needs to go through before they make the decision to bring you into the network. But it does allow us, when we're seeing patients, to use things like e-consults or what's called Ask Mayo Expert, and sometimes that helps on a very complex patient problem so that we can get the advice needed and the patient doesn't have to travel out of state. A bit about our experience in the region. Back in 1997, Pioneer Medical Center in Big Timber came to us and said, you know, we're struggling. We would really like some help with management services. And we said, well, we can look at that, and we did. And since 1997, we have employed and placed the CEO there. We've worked closely with the board, and various resources are brought to bear that have helped them. And that's a small facility that has had fragility on and off. Colstrip Medical Center is a clinic, not a hospital, but we've had a long relationship helping Colstrip maintain physician and other clinical services. North Bighorn Hospital is Lovell, Wyoming. Daniel's Memorial is Scobie. Roundup is a newer ad, and they really were struggling in Roundup, which is about 50 miles north of Billings, and we have stepped in to try to help them, and so far so good. Sheridan Memorial Hospital, also relatively new, that's up in Plentywood, about 40 miles from the Canadian border. So the geographic spread of all these partnerships in smaller communities has become quite large. I'm saving Beartooth, Stillwater, Livingston, and Glendive because in those 4 communities, they decided they wanted more than management services. They wanted a formal partnership where we share governance. So in all of those situations, Billings Clinic has or will have, we're just finalizing Glendive, board members, and the shared governance is defined slightly differently in each one. In Beartooth, we're a 25% member of a community association, and that's how board members are chosen. So there we would have 3 board seats, which is 25%. We employ the CEO, and in the case of Beartooth, also the physicians, because we had a physician clinic in Red Lodge before merging that with Beartooth and creating a new entity to create synergies that would really be good for that community. In Stillwater, we're what's called the sole member, which some would define as ownership. But interestingly, in Montana, sole membership is really defined by what you put in the bylaws. So at Stillwater, the board still makes the decisions. We do have some reserve powers, but we don't really have any unilateral decision-making rights at Stillwater per se, even though we're the sole member. Livingston, we're looking at having 2 to 4 board seats as we enter into a new management contract and a new set of bylaws that will define our shared governance. And in Livingston, we're very close now to having final plans for a new hospital, and we think we'll close on USDA funding in September is what it's currently looking like. And then Glendive, newest organization to seek shared governance with us. Again, we would have a minority of board seats, a management contract, and in all of these cases, we employ the CEO, but the CEO does report also to the local board, and that board has oversight of CEO performance, but expecting us to provide the support that that CEO needs. We have come to believe that a regional approach to healthcare is really important. There are a number of communities that are able to do more, retain patient care in their communities more effectively, and offer services more effectively in a partnership with us. We think that's good for the communities we work with, and actually we think it's been good for the Billings Clinic because it becomes a win-win situation when we have that joint partnership. Over time, all of these start out as something new. Trust has to be developed, shared goals, shared strategies. Each community has a different way that their board might look at things, and of course there are always personalities, but at the end of the day, it's the shared trust around a partnership where we support each other that really makes a difference. We think that the healthcare knowledge and expertise that's transferred really is useful to those communities. And I should add, in many cases, we're learning from them at the same time because the dynamics they're facing, and many of them have outstanding local boards with great expertise. So that transfer of knowledge is shared. And we do think that the management methods that we try to bring to bear there make a big difference in these partnerships. This just gives a sense of the number of affiliates we have. It's a busy slide. The number of branch clinics we have, and then the blue dots are all the outreach clinics that we do. By the way, we are leaving handouts at the end of the evening, and we will put this up on a website by midday tomorrow. Having sat through many of these presentations, I always tell myself, I think sometimes I hear a presentation and I remember about 10% of what went in front of me. Having this to go back to for those of you who are interested will possibly be helpful, and we'd be very happy to take questions down the road if some of you do that. These are examples of all the physician outreach clinics that we do. And you can see it's quite extensive, and we're actually going as far out now as Missoula, where we're doing GYN oncology. But it's a very busy thing for us to have specialists doing this much outreach in the region. And these usually come from requests out of the specific communities. Could you please help us with something? And again, it's very good for patients. These are the specialties, which I won't read line by line, in which we're doing outreach. Then I also wanted to say that our telemedicine program is really quite extensive. It was originally named the Eastern Montana Telemedicine Network, and we're now doing telemedicine in these many, many locations, now in 3 states. We started in clinical telemedicine with mental health. That's now expanded to a number of other specialties where we do actual telemedicine clinics, so to speak, and follow-up. We also use the network for administrative meetings. And again, the various specialties in which we're doing telemedicine. And I won't read the numbers there, but the number of conferences, the number of participants, the number of patients that we reach are quite significant. And then I would say that our information services regional approach is reasonably unique. We now provide financial IT systems, clinical IT systems in 17 communities. We're getting requests from communities who are not in partnership with us in other ways. Our most recent discussion in terms of somebody who might want to talk to us came from Arizona because of the experience we have developed in how we can place both financial and clinical information technology. And we have a strong track record of implementation, successful implementation, and we've negotiated contracts that allow us to give very competitive pricing in this area.